Okay, so welcome everyone. My name is Megan Ramos, and I'm the Foundation Program Coordinator with the Riverside Medical Clinic Charitable Foundation, and we do these webinars monthly, and so we hope that you'll enjoy this and join us again for the next one. If in any case you lose internet connection or you have to leave before we're done, a recording will be sent out through Webinar Ninja afterwards to the email that you registered with, and then within a couple days it'll be up on our YouTube page as well. And then a couple housekeeping things. On the right side is a chat box, and you can feel free to type in there anytime. If you have any trouble with the program, I can respond and try to help you with that as well. And then if you scroll down, there's a questions portion, and we'll be using that portion towards the end of the presentation today. But you can type questions at any time, and I'll read them at the end. So with that, I'm going to pass it over to our speaker. It's Dr. Arrington. He is a widely recognized expert in minimally invasive gynecological surgery and advanced excision of endometriosis.
Hello, everyone. Boy, this is a first for me. I've never done a webinar on my own. I've been a participant in panels and things like that where I just get asked questions, so I don't have to think on the fly too much. I wanted to just start off a little bit. I've been thinking about what to prepare for this webinar, and I know as we come into March and really through every day of the year, there are so many discussions on support groups and among endometriosis patients and providers and all of us who are involved with endometriosis care. And I wanted to try to see if I could pull some things that maybe aren't discussed on a routine basis. A lot of the things we're going to discuss, or I'll discuss, are the normal things, but I do want to try to pull in some of the other aspects of endometriosis care and why we are where we are. I know I originally had proposed it as a kind of endometriosis and politics discussion, and there still is going to be quite a bit of that. I blame the politic interest on my grandpa, who was a state legislator for 20 years. I grew up campaigning for him and really fell in love with the whole political thing. And as some of those that follow my personal Facebook page, I get a little bit too carried away. Let me make sure. Yep. That I get carried away a little bit with political stuff. I want to throw out a little bit of my history just to gain some understanding. I went through a normal GYN residency in medical school and through residency. I always loved surgery. I always really found an affinity toward laparoscopic surgery, minimally invasive surgery, and always told myself that I wasn't married. If I weren't married and had a family, I would probably have been a trauma surgeon, even though that isn't laparoscopic care. But I really fell in love with laparoscopic surgery and minimally invasive surgery during residency, and went on to do a fellowship with the AEGL and Society for Reproductive Surgery with Dr. C.Y. Liu as my mentor. And that was an absolutely unreal experience to stand across the table from him 4 days a week for an entire year, just he and I, and learning everything, trying to learn everything that he could offer to me. Really, since then, I've been in private practice, so I've grown up, quote, grown up outside of the world of what we call academia, those medical centers, residency programs, university-based hospitals, focused on the academics of medicine. I call this, I guess, my real-world experience. I came out of my fellowship just wanting to be able to offer minimally invasive surgery for all the normal things in GYN care. But as time went on, and I continued to grow up under this scenario, I realized that there is a very, very large need for good endometriosis surgery. Right now, that's the best that we have. Clearly, we would all like to see an improvement in options. If there were ever something that we could use outside of surgery to treat patients in a better or more complete way, that would certainly be the optimal way to go. But for right now, advanced excision surgery is the best that we have for this disease. During the course of that time, I started out general OBGYN. I delivered babies. I did surgery. I always liked the surgery aspect of it. Over time, I got busy enough surgically that I had to give up delivering babies. And even beyond that, because of the need for endometriosis care and endometriosis surgery, I ended up devoting my time fully to endometriosis surgery and stopped doing routine GYN preventative care, annual visits, that sort of thing, and even gave up a lot of the more simple surgeries to some of my colleagues in order to keep space open for the endometriosis patients. During that time, and growing up outside, in a private practice, real world experience, I really learned, I think, to listen to my patients. I learned to listen to their experiences. I learned to listen to their struggles, their symptoms, and really try to tie that in with what I had been seeing from endometriosis as a disease. I learned not only to listen to the patients, but I also learned to think about what they were talking to me about and how that could play a role in the care that I offer or recommend. Clearly, as most of you and myself over time, I became very dissatisfied with what we consider the standard of care or the standard treatment. There are too many endometriosis patients where their disease is allowed to progress and go untreated purely because doctors are focusing on one of two issues. They're either focusing on fertility or they're focusing on pain, and we forget to look at the patient as a whole, that there's so much more to a patient than just pain. There's so much more to a patient than just fertility. And when we limit our focus of endometriosis care to one or the other and forget the other one, but also forget the patient as a whole, we lose a lot in our ability to appropriately care for our endometriosis patients. Most of these other aspects that are forgotten about are the interpersonal relationships, how this affects our patients on a personal level with their ability to work, their ability to go to school, their ability to have relationships with family, with partners, and all the social aspects that come into it, the problems of dealing with a chronic disease, the mental anguish is the word that comes to mind, or the mental struggles that come from dealing with endometriosis as a disease, when really we could do a much better job at catching these patients early. And I really feel of being able to prevent a lot of these long-term extra things that endometriosis patients deal with. As we get into different endometriosis care options, those who have followed me a little bit, either on my old website or on my Facebook page, I often come back to something called the Dandelion Analogy. And really, I feel this explains endometriosis care and our options for endometriosis treatment and management in a really good and easy way to understand. Imagine looking out into your yard and your lawn is full of dandelions, and with that you have a number of different options. One option is just to ignore them, to not care about them, realize that they're there, realize that they can be a nuisance. Some people will pick them and use them. But that's one option with endometriosis care, is just to ignore the symptoms. Patients, that's what they choose to do. Another option is to realize that you don't like the dandelions there and you want to kind of hide them or do something with them. So you take green lawn paint and paint over the surface. And really, this is what taking hormones or any form of medicine does, is it masks that symptom of the dandelion or masks the symptom of endometriosis. Even though they're still there, for some patients, it makes it so you can't tell that it's there as much as they normally would. Another option is mowing the lawn. This is the one that I equate to superficial surgery, where they go in and superficially burn across the top or laser across the top or hit a few of the lesions, where immediately after there can be some symptom improvement, or your lawn looks great after you mow it. Can't tell there's any dandelions there, but sure enough, just with enough time, they grow up and they continue because the plant itself has never been taken care of. Next, I have on my list a weed killer for lawns and for dandelions. Whatever you use, Epsom salts and vinegar, or some of the branded ones, those are meant to kill the plant by the root. Unfortunately, right now we don't have that as a treatment option for endometriosis. I know there are a lot of doctors who equate Lupron and GnRH agonists to Roundup for endometriosis, but there really is nothing that we can take that goes in and kills endometriosis by the root. And that's where a lot of the bench research is. The basic science research is going in not only to diagnosis, but potentially down the road, we could see gene therapies for endometriosis, much like we're seeing with cancer therapies at this point. Something that patients could take or be given that would go in and specifically target the endometriosis implants and potentially treat them all the way to the root and get rid of the disease. The next option is digging up the dandelions by the root. Again, this is what we can equate to excision surgery. I'm not going to hound on that too much. Another option, the last two options are the most, I guess, comical, but the sad part is patients see this all the time. Another option is to tear down the house, understanding that there's dandelions scattered throughout the yard. One option you have is to tear down the house, and it makes zero sense to do this, but that's what we see too often in patients who are recommended hysterectomy to treat this disease that's scattered throughout the body and throughout the pelvis elsewhere. If we just tear down the house and remove the uterus, then they'll be all better. And it makes zero sense when you think of this from a disease standpoint. The last one is the one actually that a patient added when I first put out the Dandelion Analogy. And often patients are told that it's all in their head, or that, you need to get a psych consult. I had a patient recently that her provider told her that she was just masking abuse from when she was a child and had extensive endometriosis scattered throughout her pelvis. So the final option is just to convince yourself that you're crazy. Convince yourself that there really aren't any dandelions when you look out the window. And that really, I think, encompasses most of the options that patients are taught and offered as treatment. I want to get into a little bit now what I call a section I call Acog Standards. And this is a part that really has bothered me for a few years. When we look at standard of care for any procedure, we have organizations who go over data and make recommendations. In Acog, those are put out as practice bulletins. And supposedly they review all of the available data, and then they just present a discussion on the disease process itself and different treatment options and management options that providers and patients have. And in the Acog Bulletin, the problems I have with this is, again, it comes back to a general focus of we can treat pain or we can treat fertility. Very little discussion within that document about actually treating endometriosis as a disease. And they lose a lot in really presenting patients the options that they need to fully understand the disease. But then the providers get lost in that too, because they're misdirected in treatment options that they really should be offering to their patients. There is a general focus. A majority of that document, or a large part of that document, is spent discussing all the various hormone therapies, from ibuprofen to birth control pills to progesterone pills to IUDs and GnRH agonist Lupron type medications. A lot of that document is spent talking about hormones, how well they work, if they don't work. They even discuss really a little bit of what the role is. And the only role that has ever been shown with any of the hormone therapies is control of symptoms. There are no studies that show that it actually treats the disease itself. And that goes completely against what most of your doctors are going to teach you or tell you when they're presenting options. They're going to tell you the most common one now, and often I'm seeing this, patients presented with Orlissa or elagolix as a first-line option, that you go in to see your doctor and there's concern for endometriosis, and right off the bat they're offering this, what many would consider a second or third tier medication, because it's the newest, latest, greatest thing. And there's too much focus just on control of symptoms, and we forget about that whole patient. The interesting thing about this document is that as you read through carefully, they actually do cover some of the roles of medicines. They're very clear throughout that document that Lupron is no better than birth control pills and has been shown equal to a Mirena IUD as far as controlling symptoms. Yet doctors use Lupron as a second tier option. Boy, if you can hear the guy doing the weed eater out in the yard, I apologize for that. Hopefully he'll pass soon. But they don't even realize that the data they're presenting shows that these medicines are all equal and that their only role is pain control. And they admit in there that there's no data that shows that any of these hormones prevent endometriosis from progressing. But you almost never will hear that from one of your physicians. That it's always touted as, we use this to prevent progression or suppress the disease. But honestly, I haven't ever had anybody explain to me what they mean by suppress the disease. I've heard physicians tell their patients that Lupron's going to make the rest of it go away or kill it off, but there is zero data to support that. One other big issue I have with the current Acog statement is there is a discussion in there regarding hysterectomy. And they include hysterectomy and removal of the ovaries as, quote, definitive treatment of endometriosis without any supporting evidence. They base their recommendation or base the discussion off the statement that many providers consider hysterectomy and removal of ovaries to be definitive management of endometriosis. They are making a very drastic recommendation that, in my feeling, truly has harmed many patients, many young patients, many patients who maybe had goals and aspirations of having a family, but were told that hysterectomy is the only option they have left to treat their disease, and it's definitive. We've had patients who are told by their providers, we've had patients who have been denied care for endometriosis because they've had a hysterectomy and their pain therefore cannot be due to endometriosis. And all of this based off the idea that many providers consider. There's without any clinical evidence to support that discussion or that recommendation. Another interesting thing to me is we look in the world of GYN surgery and management of difficult gynecologic pathologies. And the one that most closely resembles endometriosis is GYN cancers. We look at ovarian cancers, uterine cancers, cervical, some of those other ones. The most common one I think that would equate to endometriosis would really be an advanced ovarian cancer, where there's disease spread everywhere. There's adhesions that form everywhere. It is a very difficult surgery. Really, there are no regular GYNs, if they see a patient with a GYN cancer, who would take that cancer patient themselves. And they would go to the operating room. They would approach it to go in and surgically debulk the disease or remove as much as they can. We all refer our cancer patients to those who are appropriately trained to not only surgically treat that disease, but then also continue their management with chemotherapy or radiation, whatever's appropriate afterward. And it's kind of grown up this way because everybody realizes that this is difficult stuff. Most gynecologists are not trained to perform that level of surgery, and most gynecologists don't want to have to, quote, deal with those advanced cancer sick patients. It's a difficult area of medicine. The thing that we forget is endometriosis can be equally as difficult. Those surgeries often are more complicated than, say, uterine cancer patients, sometimes cervical cancer patients. Ovarian cancers can be pretty comparable. But these are very difficult, very invasive, very destructive surgeries for a very destructive disease. But for some reason, regular gynecologists don't feel a need to refer these patients on to those who are appropriately trained to take care of their disease in the best and the safest way that we have. I had a quote here that I wrote down. You see me glancing at my notes a little bit, but this is one that I wanted to bring out specifically. And I wrote, "Why is endometriosis so different? Apparently, the impact of endometriosis on pain, on relationships, on work, on school, on mentality is not felt to be critical enough. We see the criticality of this with cancer patients, but we do not see that critical nature. We do not see that urgency and that desire to get these patients appropriate treatment with endometriosis." And I think for you as patients, it really makes you feel, or patients that I've talked to, it makes them feel that their condition and everything they deal with on a daily basis in their personal lives and in their relationships is just not critical enough to the medical community. And that's absolutely tragic. And that's really what we're trying to push to change. Boy, there has been it's been fun for me over the last few years as I've become more involved with the Facebook groups, with the petitions to Acog, working with all of those advocates that are really pushing with this. It is so much fun to see the patients get on board. Sally for the Endometriosis Summit that just took place. One of the first, if not the first, that really pulls patients and providers from all aspects of endometriosis care to just sit and talk and present what we have learned to be the best treatment options and the best approaches to endometriosis care. Again, regular GYNs would refer their patients to oncology specialists to discuss treatments for cancer. So not only performing the procedures, but as a regular gynecologist, I don't even present those treatment options to the patient. Once I find out that they have a cancer, I refer them off to the oncologist, and it's the oncologist that reviews all the imaging, reviews all the records, potentially reviews, surgical reports and pathology. And they're the ones that sit down at that point with the patient to go over all of their options. On the flip side, with endometriosis care, we have the general gynecologist that maybe does one or two, a few endometriosis surgeries a month, rarely ever does an advanced endometriosis surgery. And they're the ones that are presenting the options to the patients. And they're presenting options that, again, as we've talked about with understanding the Acog document and hormone therapies, they really don't understand the role of the options that they're discussing with their patients when they're talking about birth control pills and progesterone pills and Lupron to suppress or to kill or to get rid of the disease. They're presenting these options without a full understanding of what their role is. And as they talk about surgery, they always throw out, we'll go in and do surgery and we can burn what we see, but most patients, we have to come back in 1 or 2 years to do it. It just keeps coming back. They use the term coming back when in reality they're going back for disease that is still persistent, the disease that was left untreated and really never went away. And sometimes patients will bring up excision to their regular gynecologist, and frequently we'll hear back from patients that regular gynecologists just kind of push it to the side and say, no, that's too risky, it's too aggressive, you'll be damaged, you'll be injured. And clearly attacking endometriosis in a more aggressive way does carry some more risk, but that's where the importance of going to someone who deals with advanced endometriosis on a regular basis comes into play. Similar with a cancer doctor. You don't want somebody who's doing, 1 or 2 cancer surgeries a month. You want someone who is dealing with that all the time. And by doing that, we become familiar with the anatomy. We become familiar and more efficient with our approaches to endometriosis disease, depending on where it is inside the abdomen and pelvis. We gather teams around us who are very, very good at helping with the endometriosis surgeries in complex cases. And when doctors just flat out tell their patients, oh, you had endometriosis in the bladder or you have endometriosis on your bowel, and it's just too risky to treat, they often just throw that out as a blanket statement without even really understanding what that risk is. They don't understand that you can remove endometriosis from the bladder and repair the bladder, and the bladder is actually very forgiving. If you rest it and repair it appropriately, the bladder typically heals up very well. And same thing with colon surgery. We all worry about complications from bowel surgery. And that's just a reality of doing surgery on the bowel. But when we present patients the option of complete removal versus partial treatment, most of them are going to, at least in my experience, are going to choose full, complete removal of the endometriosis. And what their regular gynecologists don't understand is, yes, there is a risk of complications from that surgery, but the major complications of a bowel leak or an anastomosis leak fall in, from studies that I've seen, 2% or less. Most of these patients, as long as we do appropriate bowel care afterward, heal up very well, and the quality of their life is significantly improved by removing this advanced, crazy, invasive endometriosis disease. And these are the numbers that the regular gynecologists have no clue what they're really even talking about, similar to the hormone therapy, is that they just throw out generalities without really understanding the disease itself and without a full understanding of the options that they're presenting to their patients. Another interesting thing that came to mind, and I truly believe this after working on various committees with other hospital systems and insurance programs, most regular gynecologists, to tell you the truth, probably have rarely ever reviewed an endometriosis article. Not just the more recent ones that we're trying to pull in supporting excision and management of this disease, but I look back to my residency program, and to tell you the truth, I can't remember a time when I actually pulled an endometriosis article and read through it and critically reviewed it. I based all of my endometriosis training and understanding at that point from the lecture I had in medical school, as well as when I ran across an endometriosis patient in the clinic or in surgery, on what my attendings and what my professors taught me about the disease. I can't remember ever reviewing and pulling an endometriosis article or articles to do a critical review to any great degree. So most of the gynecologists coming out, they may have reviewed an article here or there. Most of those articles are old, but they're basing their management off what they were taught by doctors who really don't know how to treat endometriosis. And that's where we see generation after generation after generation of doctors continually presenting the same things that they've been teaching over the last 25, 30 plus years, and ignoring all these advances that we're seeing in the excision world. I have here that they basically regurgitate what they were taught. I come back, whenever I think of this aspect of endometriosis treatment, I come back to one particular case during residency. I was a second-year resident. Or no, actually, at that point I was, what was it? I was a senior resident. So my fourth year of residency, and I was operating with one of my colleagues that was a fellow resident just a year ahead of me, and she was working in the community at that point. We went in to do the endometriosis surgery, and it ended up what I call, and what others have called, a peek and shriek, where they get the camera in there and see complete stage 4 endometriosis, frozen pelvis, everything just stuck together. And she called one of her partners in to take a look at, just to get his recommendation on what the next step would be. And his direct quote was, just close her up and put her on Lupron. And that's the understanding that we're taught for the most part in residency. And that may be changing a little bit at various programs, but that's what my experience was. There's very little understanding of the role of advanced management of endometriosis surgery. I want to pick on Acog a little bit more. That's been one of my personal hot topics, and have been fairly active in communications with them over the last year as they're reviewing the endometriosis bulletin. Dr. Hal Lawrence was the president of Acog for 2018. And I believe, if I'm correct, he was the speaker at the end of March last year. I may be wrong on that, but I ended up pulling a quote from him, and he said, Acog is aware of the sensitivities and concerns surrounding timely and accurate diagnosis and treatment of endometriosis, which, we hear that, and it's wonderful to hear. We want them to recognize that this is an issue. That's what the patients struggle with, and most of us who do a lot of endometriosis work really feel that that's what gets patients into trouble with advanced disease, is that the delay in diagnosis is so significant that their symptoms are palliated, or they try to control symptoms for so long that the disease is allowed to progress and become destructive. So any comments or any focus on decreasing the delay in diagnosis, we would cheer it. The problem is it seems for the most part that those are just words. Since that statement came out, there have been two major announcements in care for endometriosis, at least in the United States. The first one that came out was the Acog Bulletin on treatment of adolescent or teenage endometriosis. And as you read through this document, same as the old document, they promote hormone therapy, and they promote long-term hormone therapies, first starting with simple birth control pills, possibly progesterone pills, but they also have a discussion of the GnRH agonists, and probably would have had a discussion on the GnRH antagonist, the Orlissa, if that had been approved and really become as it is now before this document came out. The problem is all of these hormones, if they do not keep a teenage patient comfortable, and even if they do keep her comfortable, or keep the patient comfortable, that over time, the endometriosis has a chance of progressing. And right now, we don't have a really good way to know which patients have rapidly advancing or destructive endometriosis and which patients are going to stay fairly minimal. And if we know that it's fairly minimal and we can control their pain with hormones and they're okay with that, that's the option they choose, then there may be fairly minimal risk with that. But the problem is we really don't have a good way to know which patients are going to be destructive and which patients are going to stay in that minimal range. And by continually dumping hormones, or what I've heard other doctors coin the term hormone shopping by the doctors. Well, if this one doesn't work, let's try this birth control pill. Let's try this birth control pill. Birth control pills aren't working. Let's try the progesterone pill. And if that's not working, let's just try, let's try Lupron. Nowadays, they go straight to Orlissa as the new thing. And we continue the perpetuation of delay in diagnosis. All of these stepwise hormones and all of these things that we do and we're taught to do to avoid surgery because surgery is too risky is really what gets patients in trouble with their advancing disease, that oftentimes we get to the mid to late 20s in some patients, and it's just destructive and it's heartbreaking. And potentially even worse than that, where the patient has struggled for so long and hormones haven't helped, so their doctor's gone in and done a hysterectomy and potentially removed the ovaries when there's been documented endometriosis all along the course, where this could have easily, or even if it's difficult in most cases, a surgical endometriosis specialist could have managed that disease. Certainly, the earlier we get it, the easier it is, but in most patients, we can avoid the need for removing the uterus and the ovaries to treat this disease. The second major announcement, again, is with Orlissa, with the brand new first treatment in 10 years for endometriosis. The caveat is we have to remember the phrase on the end of that. So it's not a new treatment for endometriosis, but it's a new treatment for endometriosis-related pain. And often providers, and it gets perpetuated as well, that this is a treatment for endometriosis, and they forget related pain on the end of that. That's the main understanding. Again, it's another medicine that, as far as we know, doesn't work any better than a birth control pill, but is incrementally more expensive. But it is another medicine that doctors will throw into that whole stepwise treatment plan that is going to further the delay of diagnosis of endometriosis, diagnosis and hopefully treatment at the same time. So even though those, quote, higher ups in Acog are talking about delaying diagnosis, I remember the Acog president the year before, Dr. Lawrence, basically the same thing. We've got to work on decreasing the delay of diagnosis. Yet all of their documents that they put out and all of the major announcements in endometriosis just are there to control symptoms, and they don't treat the disease. And it further delays that diagnosis and encourages doctors to continue to prescribe hormone therapies. Another interesting thing with the adolescent or the teenage patient with the recommendation of hormone therapies is, I mentioned that the Lupron and the GnRH agonists, the GnRH antagonists, now Orlissa, and even Depo-Provera are thrown into the mix. The thing that, other than not really treating the disease and not being any better than a birth control pill, one of the things that bothers me the most about including these medicines in the discussion of a teenage patient is these are medicines that are very inhibitory or that very destructive to bone development and bone density at a time that is the absolutely most critical time for building bone density and bone health in a woman's life. In the late teens and early 20s and through the 20s is the most critical time for patients to be, for females, to be putting good, strong bone structure and building that bone density that will carry them throughout the rest of their lives. And here we are placing these young patients on medicines that directly counteract that bone building. And in the case of Lupron and likely with Orlissa or elagolix, that may not be reversible. For Depo-Provera, it does seem to be reversible once the medicine that is stopped, but there have been documented cases, at least with Lupron, where that is not a reversible bone loss. And we're putting these young patients on a medicine that could cause even more significant problems as they go throughout their life. The last thing that I want to formally discuss, and again, this has been something that I have shared my thoughts and feelings with those at Acog who are preparing their practice bulletin and their recommendations for endometriosis care, and that is the idea of informed consent. As a GYN medical community, I feel we are very, very lacking in how we give an appropriate informed consent that really will allow a patient to make the best decision for her. In my practice, I coined this, my ibuprofen to hysterectomy talk. I keep using my hands, but I think my hands are mostly out of the screen. But I coin it my endometriosis to hysterectomy talk. And I include everything in between. I actually include one before the ibuprofen, and that's to do nothing, to just do observation, to just ignore the dandelions that are in the yard. And that needs to be presented as an option. Most patients have passed well beyond that. You get to the level of care that we are at the Center for Endometriosis Care. And most of these patients are already well past the first few options in that: the observation, the ibuprofen, the pain medicines, the early birth controls, the hormone therapies. But I include that discussion of what the role of hormones is, and it's purely palliative. They're purely symptom control. There's no evidence that they prevent disease progression. And again, nobody has ever been able to tell me what they mean by suppress. They don't make it go away. We do talk about what surgery most gynecologists are going to offer. They're going to go in and superficially burn or partially treat. What is not discussed with those patients, yes, that's a treatment option. But often we find as we as endometriosis specialists are going in again to operate on these patients, we often find that the disease and adhesions are now more difficult to manage because there has only been partial treatment in the past. That when surgeons go in and partially treat the disease, especially in cases of advanced disease with endometriomas and already some initial scarring and adhesions, they'll go in and maybe release the fluid out of an ovary, and then I took time, 1 or 2 hours, an hour to free up the adhesions, and worked really hard to free up these adhesions. And when I was done, everything was in its normal place. But what they fail to do is then go and remove the disease that caused the adhesions in the first place. So now a patient, as she recovers and as her body heals, she is dealing not only with chronic endometriosis inflammation, but now she has surgical inflammation on top of that. And it's the inflammation that causes the adhesions to form. So often we will see that partial treatment results in a disease that is more difficult to treat the second time around. The next option we talk about is excision, and the goals of that. Certainly as endometriosis surgeons, our overall goal, all of us, is to be able to recognize what is endometriosis and then to remove the disease. And that needs to include a discussion on fertility, on if the patient wants to keep the uterus, to keep the ovaries, to keep the tubes and maintain fertility. There may be times when a full, complete excision of endometriosis and disease cannot be completed because a patient wants to maintain the fertility. If I had to guess at the number of those patients in my practice, it may be 5% at the most. Most of these patients, we can get the disease removed while still preserving fertility. But we can, to really discuss where we commonly find endometriosis, what the imaging suggests, what my exam suggests, what we really may be looking at in these possibilities. Is it in the bowel? What are the risks of leaving it in the bowel? What are the risks of removing it from the bowel? And we need to talk about both sides of that risk, because there is risk of doing nothing, and there are risks to removing the disease. But it's important that a patient understand what those risks are, how it's approached, how it would be managed if a complication arises, and allow her and her family to make the decision that is best for her. The hysterectomy, again, is a personal decision. In some patients, that may be the appropriate way to go. If we know that there's concern for other things within the uterus, or a patient just, is done and she just wants the most complete treatment with the lowest risk of going back for surgery. We know that there's been advanced adhesions before. There's a high likelihood that there's at least some superficial involvement on the uterus or the cervix. Some patients, it may be appropriate to choose a hysterectomy, but we need to present that as an option. The failure in the GYN community when presenting their patients with options and offering a truthful and complete informed consent is when we get to the discussion of surgical management. They, again, in their experience, they share what their experience is. We can go in and do surgery, but, we still need to go on hormones afterward, or we're just going to be back here every year or two to clean up the disease as it comes back that we know really doesn't come back in most. It's just persistent. They fail to discuss a referral to someone who can actually excise and cut out the disease, especially in those advanced cases. They just tell them that it's too risky, or really don't have a full disclosure saying, if I find that it's in the bowel, I'll pull in a general surgeon and he'll help me with that. But they don't really tell you that, it's very likely that they've maybe only done that, sometimes never, maybe sometimes 1 or 2 cases a year at most. Most of the general gynecologists are not going to touch colon disease or bowel disease. They're just not. And they'll just kind of wake the patient up, tell them they got what they could, and then put them on really their only option, or their go-to option is Lupron, or probably now Orlissa. But that's where the big failure in informed consent comes. And in my discussions with Acog as a practitioner and as a provider, I feel that's where they are failing us when they set this quote standard of care, is they're promoting this idea that surgery is a last option, that surgery is too complex, surgery is too risky for patients to go. And they keep coming back and telling us, we didn't include that because there's not enough data to support excision and removal of endometriosis, where a lot of the advocates have submitted pages of study references regarding that to support excision. But yet they turn around and they include hysterectomy based off the idea that many providers consider, or many providers believe, without any supporting evidence in the literature that hysterectomy actually treats endometriosis and keeps it from, quote, coming back, and magically makes the other disease go away. So there's a complete double standard on what they will include in that document and what they will not include in that document. But that really needs to be where the informed consent goes. Patients deserve a full and truthful informed consent. And I've seen colleagues in my old practice that they understood what I do. We've had patients that we've managed together. Some of them, especially in my own personal clinic that worked with me, if they found a patient where they had endometriosis in an area where they were not comfortable going after it, they would take the pictures, they would document what was there, and they would refer her on. Then there were other doctors in the community. We'd worked together in the same community for 10, 14 years, and they know exactly what I do. They know exactly how we approach endometriosis. And when they found patients with stage 4s, for the most part, these patients, the ones I saw, ended up finding me on their own. That they were not given that option to say, hey, this disease is really advanced. It's well beyond what my capabilities are. Our options are we can continue trying to treat the pain with hormones, with the understanding that the disease may get worse, or I can refer you to this colleague of mine who has more experience with endometriosis and see if we can get the disease taken care of. Informed consent should be a big red flag for providers when it comes to endometriosis. It is, I hate to throw it out, but it is a medical legal risk when we do not offer a full and complete informed consent to our patients. And we would never hope that it gets to that point, but clearly there have been patients harmed by the current standard of care. One of the phrases I've coined over the last year, maybe 2 years, is the standard of care is not sufficient. The options and the education and the understanding of endometriosis treatment that are put forth by Acog are clearly not sufficient. We have too many patients that struggle. We have too many patients that cannot access appropriate care. both in the U.S. as well as throughout the world. The understanding needs to be better, and we need to be more supportive of our patients. To go back to my early career days, to just sit and listen, and not only listen but think, how can I help this patient, or what can I do better, what can I change, or where can I send her to get better care? To consider the patient more than to consider me, to consider my capabilities, to consider my practice, to make the patient the top priority. Anyway, that's kind of the gist of my prepared remarks. I ended up rambling on more than I ever thought I would. But let me go ahead and stop the formal.
It looks like we lost sound. Is your hand on your microphone?
Maybe.
Oh yeah, I can hear you now.
I probably have it covered. Yeah, let me just pull in, or let me just back off then, and maybe let you ask some of the questions that you've seen come through.
Okay, great. Yeah, we have a lot of good questions that have come in. So we'll start with, where do I get help for thoracic and pelvic endometriosis symptoms post 4 surgeries, stage 4 endo and hysterectomy? I've reached out to an endo specialist, but he says it's impossible for me to have endo still.
Let me think. Now I got to think. So let me just put out how I have tried to manage patients in my own practice. And a lot of this will depend on what the findings were at time of surgery. You really have to do a good review and ideally see pictures and see pathology and all that sort of stuff. Some and am I back on? Sorry. There are times when I've gone back in on a patient, and I've tended to be willing to go back in for a second look until I can confirm that I can't see any disease there. And I may actually be different than some. When I go back in for a second look, I want to try to find the endometriosis. I don't care what my statistics are. I don't care. I mean, I do care. But my first priority is trying to help the patient. And if there's anything inside that looks like it could be suspicious, or if there's just some scarring around the nerve area or something that just looks a little bit funny, I'm going to remove it and biopsy it and send it to pathology. And if it confirms endometriosis, then I know there's a chance I either missed something or there's something new that's there. Sometimes we go in and I end up focusing just on adhesion work or on nerve work to try to free the pelvic nerves. I have one patient where we did an endometriosis removal, and boy, she just struggled with very focal right-sided pain. Went back in really not expecting to find endometriosis, and we didn't, but I also spent some time, and we just dissected out the nerves. Didn't see anything that looked overly remarkable, but afterwards she's done very well. So once we can hopefully confirm or really have a good idea that the endometriosis as a disease is taken care of, the benefit to that is it forces not only the provider, but sometimes the patients too, to kind of shift our train of thought and start pulling in all these other ideas of what can this be. That's where we get the pelvic floor, we get the neuropelviology, the nerve stuff. There's bowel issues, all kinds of different things that we can pull in, and understanding that it is a very, very, very hard aspect of endometriosis and pelvic pain patients. We all wish that we understood it better. We all wish that we could do a better job. Can you repeat that? It totally echoed. So the dangers of undiagnosed or untreated endometriosis. There are rare cases of bowel obstruction. We have patients who, if they have thoracic or lung endometriosis, will collapse along with their period. Those can be more dangerous aspects. Occasionally we'll see patients with deep endometriosis around the ureters or bladder where they have silently lost kidneys. Really, it comes to what I call the destructive aspect of it. And if I remember correctly, about 10% of patients with endometriosis have a more aggressive or destructive or invasive form. If
Okay,
left
so our next
untreated
question is
or
what are the
undiagnosed, every
dangers, if
patient with
any, of
endometriosis has
undiagnosed,
a chance
untreated
of developing this
endometriosis?
sort of disease. Right now, we just don't have a really good way
Oh, sure. What are
without
the
surgery
dangers,
to know
if
which
any, of
ones are
undiagnosed,
which.
untreated
So really,
endometriosis?
it goes to the destruction of or invasion into the intestines with bowel obstruction, into the bladder, into the ureters that could kill off a kidney, diaphragm and thoracic disease that can cause repetitive pneumothorax or collapsed lungs. But then also with many patients, the pain aspect, uh, the dangers with that is opioid. I don't want to say addiction, but opioid dependency is a better way to put it. Relationships that it affects, their dreams of family, that all that can be taken away because we are masking or not knowing what this disease is doing. It's still echoing. Can you do it again? So if diet can help cut down on endo flares, okay. Maybe when you ask questions, space the words out a little bit, and then the echo will finish before the other word comes in. I don't know why it's um, there are a lot of patients who find benefit with a quote endo diet. Low inflammatory diet, low hormone, low estrogen type of diet. They see benefits with that in an overall kind of anti-inflammatory aspect. I don't know if there's a huge amount.
Okay, so our next question is, do you think that keeping a food diary will help cut down on flares? Oh, sure. Do you think that keeping a food diary will help cut down on flares? Yeah. Okay.
Of resource to support that to a great degree, but there are certainly patients who find benefit with that. That is one of those areas. Same thing with with acupuncture and some of these ancillary things. That there really is very little risk in trying some of these. And if you find that it's helpful, beneficial, makes you feel better, then do it. It's not going to hurt anything by trying, even though they can be very challenging. The endo diets can be extremely challenging for many patients. But decreasing the inflammatory or the inflammation in the body and extra stress that that causes on the body can improve symptoms and just how they feel overall.
Okay, so can an overweight patient be operated on?
Yes, um, simple as that. Um, so overweight patients we can operate on. The things that can be challenging is number one, for the most part with endometriosis surgery, we have to tip the patient upside down. The more weight that pushes on the belly, that transfers up to the lung, and it can be harder for the anesthesiologist to breathe that patient. Things that we can do during surgery to improve that or to decrease the pressure in the belly. Normally, we operate at about 15 millimeters of mercury of pressure. We can take that down to 12, sometimes 10 millimeters of mercury. That can help a little bit. Um, but also, the more, just to be blunt, the more fat that's inside the belly, it can make it harder to move the organs around to see where we need to see. So it can be a bit more challenging. to see and to be able to access the endometriosis that's there. But I've operated on overweight patients. We just have to make some adjustments, and I always hate to go in with an idea that, you know, I'll do my best, but there is a chance. I always try to do the best that I can, and even if it's a struggle, try to work through it. But it can be fairly challenging, just depending on how much fat's around the bowel and in the belly. I had one patient even where there was so much on the front of the belly, but it wasn't so much that was around the bowel. But my assistant, instead of moving bowel, actually had to hold the front of the belly up so that I could get the camera in. And so it just makes it more difficult, but in most patients it's doable.
Okay, so is there a correlation between endometriosis and autoimmune diseases such as lupus?
Hard to say if there's a definitive correlation. We see a lot of patients kind of lupus. We see I've seen, interestingly enough, a fair number of patients with Ehlers-Danlos. We see a lot of autoimmune disease in patients with endometriosis, but the majority of them don't. I think right now it's really hard to pin down a definite correlation between the two.
Okay. Can pleural nodules on the lining around the lungs be shown on a chest x-ray and CT be endometriosis?
Pleural not. So they show up on a CT and show up on a chest x-ray. I guess they have the possibility of endometriosis. If they're pleural, meaning on the lining over the chest wall and not the lung itself, I guess there's two different pleural areas in there. But on the diaphragm, I get the short answer is they have the chance of being endometriosis. I think it's something that you'd have to correlate with pain and with symptoms. If it seems to be worse around the time of period, radiating to the shoulder, making it difficult to breathe, or radiating to the shoulder blade, that raises the suspicion that they could be endometriosis nodules. The hard part is pleural and thoracic endometriosis really is difficult to pick up on imaging unless it's more advanced. Even growths within the diaphragm are fairly hard to pick up on any imaging that you have.
Okay. How can a patient go about finding or getting a referral to an appropriate surgeon if a regular OBGYN typically does not have the knowledge or skill necessary for treatment?
And again, this may play a role on where that patient is and what the insurance policy is. There really are not many insurers nowadays that require a referral to a doctor, to a specialist. So most patients honestly can find them on their own and just reach out and start the discussion. If you do have to go through your provider, I think it's fair to just sit with them and just lay out all the things that you know and all the things that you've tried, all the things you've tried and all the things they've had you try, the attempts that they've made to treat the disease. You can pull out pictures and look at the pictures together if you've had surgery with them, and just point out, say, look, I understand that you've done really everything that you can. And most of these doctors, to tell you the truth, they really don't want to, quote, deal with the more difficult endometriosis patients, but just present the case and say, look, I know you've done your best. I know that you've really struggled on my behalf and really done whatever you can, but I feel like I have a chance to see someone who sees this more often, who has the experience to really remove the disease deeply and to do it in a safe manner and have a high volume and a multi-specialty team when that's appropriate. If you do need to go to your provider, I guess that's the way that I would approach it, but every patient is going to have a different relationship with the provider. But again, most patients really don't need a referral.
Okay. An RE mentioned a little dismissively to me that having adhesions is very common. I think he meant non-endo related adhesions. What is the difference?
Adhesions typically form from some sort of inflammation, whether it's from a prior infection, whether it's from previous surgery, whether it's from endometriosis. Adhesions can be common, but typically adhesions don't just form because they form. Usually there is some some injury or some inflammatory process that's causing those adhesions to be there. I can't tell you that I agree with that statement. Yes, they're fairly common, but I mean, even in the endometriosis world, most of the patients that we see don't have a great degree of adhesions. But the thing that we have to pull back on is yes, there are adhesions there, but what caused them to form? If it's endometriosis, then the adhesions are not the only thing that we have to worry about. We have to worry about the disease that's causing them to form. And even from an endometriosis standpoint, that's one of the things that doctors tell their patients to avoid full excision surgeries, because it's just going to make everything scar down. What patients need to know and what the providers need to know is that we as endometriosis surgeons are aware of that risk. And we take great care to have very tight bleeding control. All of us do some form of adhesion prevention, whether it's suspending the ovaries or using different products or leaving fluid in the belly, all different kinds of things to really minimize the impact that adhesions will have on these patients as they recover. We are very, very well aware that we can't just go in and remove the disease and let everything scar down. We have to try to do those things that are going to minimize the risk of that.
Okay. What are the ways that endo disrupts assisted reproductive therapies, egg count, quality, implantation, etc.?
So as far as implantation, I think that's one of those areas that we don't fully understand. Many think that it's some sort of inflammatory process from the endometriosis that's there. Egg quality is something that's always thrown out, or embryo quality. But there's something within the endometriosis that affects the body in a way that it affects the success with that. As far as, what was the word? I think ovarian reserve. Again, that is still a controversial aspect, really, regarding endometriomas and how we manage them. We know that endometriomas and advanced endometriosis can decrease ovarian reserve in and of itself. There is some evidence to suggest that ovarian reserve can be impacted, at least in the short term, by removal of the ovarian cyst. But one of the tests, the antral follicle count, actually shows an improvement. The AMH level shows, most part shows an initial decrease, but then tends to recover. I think that it very likely relies heavily on the technique and the ability of the surgeon. And treatment of ovarian endometriomas and ovarian endometriosis, I feel, is very critical to be done right the first time. If not, the more times you have to operate on an ovary, the more likely we are to damage it. But the inflammatory aspects of endometriosis, certainly the adhesions that form from the disease to block fertility, but again, assisted reproductive technology, unless the ovaries are completely scarred by and hidden by the bowel, those should be available to most patients. But chemically or in some fashion, endometriosis does tend to affect even assisted reproductive technology success.
Okay. Can an excision surgery be done in conjunction with a C-section to knock out two birds with one stone?
Truthfully, it would be incredibly difficult. Number one, the uterus is huge, and there is a massive amount of blood flow, not only to the uterus, but to the pelvis. At the time of C-section is through an open surgery. The uterus is big enough that we're really not going to have a good access to the back aspect of the pelvis. I really can't see a benefit to trying to do that at the same time. I think it would be risky as far as potential blood loss goes, and even more risky as far as not being able to fully treat the disease.
Okay. What are some of the most reputable centers for endometriosis surgery?
I am one that recognizes there are a lot of us that really do a pretty good job with this disease. Not enough, but there are a lot of us, and they're scattered throughout. I feel like I do a pretty good job. I've had some pretty good success with patients. I work at the Center for Endometriosis Care in Atlanta now, really a lot for the reputation, but also for the multi-specialty support that we have here that was lacking at my old practice in Utah. I hate to say it, but I don't want to throw throw out names because there are a lot of them that do a pretty good job. And a good, I guess, a good way to put it is there are a limited number of centers that can really run and manage the full spectrum of endometriosis. Understanding that, there are a number of good endometriosis doctors that do a pretty good job with excision for lower stages of disease. Clearly 1, 2, and sometimes early 3s, that sort of thing. But then those surgeons, and this is how I was early in my endometriosis career, I realized that there were some aspects of the disease that I just didn't feel comfortable with. But when I ran into those patients, I didn't just do the surgery and say, hey, this is what we've got. I understood that there were some centers maybe with better success and more experience and better support. And I had zero problem talking with my patient and then going to bat on her behalf with the insurance company to make a referral to one of those more advanced centers. We look at, especially, let's bring in the idea of deep pelvic endometriosis with nerve involvement. There are very limited centers throughout the world, really, who I would trust a patient to nerve endometriosis resection. It's just a critical area with not a whole lot of experience. So it really depends on the degree of disease and just the doctor that's willing to recognize, hey, this is beyond what I feel comfortable with, but I don't want to leave you. I want to help you find the appropriate place to take care of this. And to throw that out, there are lists, Facebook, all that sort of thing. There are lists that are put out there that patients can go to find out what providers are around. And none of us would ever feel bad about being contacted just to talk and let patients kind of vet us out and feel if we're a good fit or not.
Okay, so what is your opinion on the effectiveness of using Dynogest for endometriosis, and from what size should the endometria be operated?
So Dynogest basically, for me, it falls in the realm of all medicines to treat endometriosis. It has the same role as ibuprofen. It has the same role as pain medicines. It has the same role as birth control. To my knowledge, it's only been shown to control symptoms, not to actually treat the disease. The size, as far as endometrioma, is the size that it should be operated on. Really, the only time that comes into play is with a patient where fertility is the primary focus. And depending on the study you look at, the numbers that I've seen are 3 centimeters or 5 centimeters. Most of the, well, not most, but a lot of the fertility specialists that I see now push that to 5 centimeters. I think most of the studies support a 3 centimeter. Acog in their current bulletin supports the idea of 3 centimeters. But really, that's going to be a patient-specific discussion. Again, all the options should be laid out to the patient with the understanding that very rarely is an endometrioma an isolated finding. Most of those patients, especially if they have painful periods or pelvic pain and an endometriosis cyst, are going to have endometriosis elsewhere in the body. Very rarely is an endometrioma an isolated finding.
Okay. If a woman is planning to have one more baby in the next year, would it be better to wait to seek out possible excision surgery after the pregnancy or before pregnancy?
I think you just need to sit down with your doctor, present all the options, the pros and cons, and it's a personal decision. I have some patients that will go in and have the removal first just because they want to feel better. If they do get pregnant, they want to feel better. They want to be able to care for their child. And then the other ones choose to either pursue on their own or pursue assisted reproductive options and go for the pregnancy first. I feel my role as a physician is just to present pros and cons, likelihood of success with each option, and then help her figure out what the best option is for her. And every patient will have a different choice.
Okay, great. Well, thank you so much for joining us. This was a wonderful Q&A session. Thank you to everyone who attended. And we hope that you guys will join us next time. The recording will be out there for all of you to see as well. And thank you, Dr. Arrington.
Thank you. And thank you, everyone, for joining in. Again, first for me, I didn't know that I could talk so much.
It was fantastic. Thank you so much.
Thank you. Hello.
It was so great. Oh my gosh.
Good. I talked a lot.
I am so impressed. No, it's really, really good. It's really, really good. I mean, the technical aspect, that's not on you, that's on her. But other than the few seconds that it cut out here and there, it was so awesome.
Good.
Love it. Loved it.
Good.
There was a lot of other questions. I don't know if you could see them, but she seemed to cherry pick them. But she got good ones.
Okay. I mean, something like this with 10, 15 minutes, we're not going to be able to catch all of them because I talk too much.
Yeah, I mean, you need all day to do that.
Yeah.
We don't have time for that.
Yeah.
That means there's going to be high demand for you to come back.
No, that's okay. I just got to find other things to talk about.
No, I think you give that exact spiel every time. Anna called me at one point, so I missed something you said, and when I came back, everybody was very excited about it, and they said, "Can